in the youthful patient, we've got the lower orbital rim and the orbital retaining ligament are pretty close together, so for simplicity's sake, I'm just going to use those as one line. And then at the medial limbus, we've got the zygomatico-cutaneous ligament. What we have here is the deep fat that lies underneath the orbicularis oculi muscle, which would be the suborbicularis oculi fat, or the SOOF. Now, the borders of the SOOF are superiorly, the border is the inferior orbital rim. Inferiorly, it's the zygomatico-cutaneous ligament. Laterally, it's the zygomaticus major and minor. And medially, there's a joining of the orbital retaining ligament and the zygomatico-cutaneous ligament to form the trough ligament, which is a true osteocutaneous ligament. Pay attention here because this has very big implications. What this means is when you go medial to the medial limbus and you go out towards the nose, there is no deep fat pad. We are born without any deep fat pad in that area. And most people have a superficial fat pad when they're younger. Unfortunately, in our late 20s, early 30s, as that fat pad descends, we start to see this hollowing. The hollowing was there when you were born, okay? It means there's no deep fat here, so as soon as that superficial fat pad starts going south and inward, we start seeing things that we just don't love. So just for completeness sake, I'm going to draw in the top of the zygoma and the bottom of the zygoma here. So because we want to be doing this in as safe a manner as possible, we've got the external carotid coming up, and it goes under the bone, emerges as a superficial temporal and gives off a posterior and anterior branch, gives off the transverse artery, which comes off below the zygomatic bone. Up here on the zygomatic bone, we have the zygomatico-cutaneous foramen. Sometimes there's two, sometimes there's even three, so we need to be aware of that. Those branches are generally very small, but we tend to inject on the bone, so you need to be aware of that. Along the mandible, we have this guy who comes along, and at the anterior border of the masseter, arises, takes a circuitous route, gives off superior labial, inferior labial, goes over to the piriform. In most cases in the piriform, it's in the mid to superficial level, but at 0.2%, or some people believe more, it's on the bone. We have to be aware of that. And there's a lot of variation in anatomy, but classically this comes up and becomes the angular artery. Again, it's a medial limbus. We've got the supraorbital artery, where she has her corrugator crease. Within 1 to 2 millimeters, we've got the supratrochlear artery. These give off some branches downward. And then again, at the level of the medial limbus, at about 0.8 centimeters below the infraorbital rim, we've got the infraorbital foramen. We've heard about that hooded structure that can keep us safe but can get us into trouble if we do the wrong thing, as Dr. G pointed out. And that's going to give off some branches. This one comes, and we saw some just beautiful anatomic dissection by, thank you for traveling from Morocco. That was a long trip. But this facial vein takes a more direct route. And what's interesting about this guy is this one becomes the angular vein, but it actually goes through the orbicularis oculi muscle. And it can be pretty big in there. So the consequences of this are that when you are medial to the medial limbus here, in this region, that is called swimming with the sharks. If they have infraorbital hollowing, by definition, their superficial fat pad has started to come down, and so they pretty much have medial cheek flattening. And if you ignore that, you're not going to be able to get away with less filler, and you're not going to give people don't just want cheeks out there. They want a nice, youthful apple cheek that they used to have. And even in this beautiful woman who's young, she has a little bit of nasolabial fold because this used to be there. That's where it was in her early 20s. You can put filler lateral to that and massage it over, or you can do this with I personally never go medial to the medial limbus with a needle. I do go with a cannula. Dr. G has done a great point of emphasizing the fact that never, ever, ever go up with a cannula. Just don't do it. You can get into the artery, you can get into the vein, and you're just asking for trouble, and that's, a direct route, right to the back of the orbit. Puncture, and then you want to be in the deep fat pad, in a deep space. If you are in the more superficial space, it will look fine while you're putting in the filler. It really will. But when the patient smiles, they will look a little alien-like because it will bulge. So it's a little spicy as you cross the infraorbital foramen. I will often give my patients a little 2% lidocaine block ahead of time. But you want to be deep in here. You want to use a 25-gauge cannula or a larger size. You want to constantly move that cannula. If you're stationary, don't push the plunger. You want to be gently putting down small amounts of product, be patient, and basically, if you're unlucky enough to be in a vessel, you want to hope that you're in and out as quickly as possible with as little as product as possible. And so there is no safe place on the face, period, none. Is this higher risk? Yeah, but do you want to try and give a complete result? Yeah.